So we talked last time just kind of about heart muscle function. We looked at the different action potentials in heart muscle and which of the muscle cells that we see in the heart have the ability to spontaneously depolarize. We call them the pacemakers of the heart. Where are those found? Yep, SA node. Anywhere else? AV node. Purkinje fibers. Bundle of His. One more. Bundle branches. Yeah, that whole conduction pathway represent that 1% of cells that can spontaneously depolarize, right? So if I transplant a heart from one person to the next, that heart will beat on its own because of those cells and their ability to drift towards threshold. So be aware that there's two different types of action potentials in the heart, right? And what causes that drifting to threshold is just the voltage-gated channels opening at that lower potential after repolarization. So if you think about the ions that we talked about for action potentials, we started talking about that in the skeletal muscle, and then we talked more about it with cardiac. What would be the effect, for example, like they tell you you're never allowed to give potassium by IV push, which means straight into a vein. You can do it through a bag, dripping slowly, intravenously, but we don't give potassium chloride directly into a vein like we might give a medicine. Why do you think that is? What is the effect, what would you predict would be the effect of potassium on the heart?
It would change the rhythm or reset.
Well, think of the action potential in skeletal pacemaker cells and contractile cells of the heart. Where is potassium involved? What does it cause? Repolarization, right? Repolarization. So it ends the stimulus, right? It ends the contraction. So if I have a lot of potassium in the environment, what is that going to do to the heart? It's going to stop the heart. It's going to slow it and then eventually stop it. So potassium, the effect of potassium, excess extracellular potassium, which leads to intracellular potassium, is going to be stoppage of the heart, right? So that's a key concept that slows the heart. And electrolyte imbalances affect rhythms. Would you agree with that? So if I have sodium or potassium imbalances, that's going to affect the rhythm as well? Yeah. So that's an important thing that we look at when people come in. Patients come in with just electrolyte imbalances, dehydration, fluid overload, heart failure, the common reasons that the elderly come into the hospital. We have to establish those electrolyte imbalances. So we get a blood test, right? And that's where we look for those electrolyte imbalances. So hypernatremia, hyponatremia, we talked about that, hyperkalemia, hypokalemia. We're going to be spending a lot of time looking at electrolyte disturbances in the next couple of weeks in lab and how that affects the body and what we look for and what's normal and abnormal and what causes it and how the body responds. So we'll look at all that in lab. So now today I just want to pick up with the conduction system. So we looked at the action potentials. So we know that the sinoatrial node is the pacemaker of the heart. And the reason why we call it the pacemaker of the heart is because it has the fastest rate of depolarization. So the action potential frequency is the highest at the SA node. The other ones can also be pacemakers of the heart. If the SA node shuts down, the next fastest action potential generator is the AV node. And if the AV node would shut down, the next fastest action potential generator would be the bundle of His, bundle of branches, and Purkinje fibers. They all kind of work together at the same rate. So the SA node, even though we call it the pacemaker of the heart, they can all be pacemakers. So in the case of like heart block, where there's no conduction between the atria and the ventricles have their own rhythm, and the atria have their own rhythm, because they all are pacemakers in and of themselves, but it's just how fast they generate that beat is what matters. So if we look at, for example, the SA node, it normally fires, your textbook says 75, but other references have said 100. Intrinsically, which means without influence of the parasympathetic nervous system, it fires about 100 times a minute. So then if a person then has a normal heart, normal SA node, parasympathetic stimulation, some of it, some tone, slowing that heart down a little bit, that brings it down to about 75, right? But if the SA node would stop firing, then the AV node takes over. And this is from page 681 in your textbook. The AV node fires about 50 times a minute. So if the SA node is non-functional and I see a heart rate of 50 and I see a P wave, which means the atria are contracting, then I can say, okay, maybe the AV node is taking over here. Or this person is really fit, right? So we know that people that are marathon runners have very low resting heart rates. And then again, if the AV node shuts down and all we have is everything beyond that, like the bundle of His Purkinje fibers, that's 30 times a minute. Now, can we survive with a heart rate of 30 beats per minute, do you think? No. It's hard to sustain life with that low of a heart rate. We need pressure to push blood out of our capillaries into our tissues to feed our tissues. So we need a little higher force and rate from the heart than 30 beats a minute. So what will happen is we have an overriding control outside of this pacemaker pathway. And that is extrinsic innervation. So we're going to talk about today how the nervous system overrides or supplements that intrinsic rate that we have. I want to mention one more thing before we do that, and that is the impulse at the SA node, even though the SA node is in the ceiling of the right atrium, notice that that pathway, when the SA node fires, that impulse goes over to the left atrium. So they both contract together. It's really important that you understand that. People that really don't know heart function very well think that the right side contracts, then the left side contracts. That's not the case. Both atria contract together. So this action potential that's generated at the SA node goes across to the left atrium, and they both contract together. Then the impulse travels down to the AV node, and it pauses there for a minute before it goes on the pathway. So it says it's delayed by 0.1 second. In looking at your online activities, what did you learn? Why is there a delay at the AV node? What? Yeah, to give time for the atria to completely contract and fill those ventricles with blood. So there's that little pause, that little delay at the AV node before that impulse continues downward. So again, what is the reason? Why does this impulse go to the left atrium, but it doesn't go down to the AV node right away? Or even backing up from that, why does it go to the left atrium, not, down the outer walls or down the middle of the ventricle? What forces it along this conduction pathway? These are all contractile muscle cells. Okay, there's gap junctions between the muscle cells, but all cardiac muscle cells communicate with gap junctions, so they function together. Remember, cardiac muscle cells don't need their own little axon terminal like skeletal muscle does because of the gap junctions. So if all the cardiac muscle cells have gap junctions, what keeps this on the pathway? And it's actually a pretty easy answer. So what would you think? What keeps that action potential going from the from the SA to the AV down the middle of that interventricular septum and then up the walls of the Purkinje fibers? How do we prevent any electrical impulse from going where it shouldn't go? Like in this wire here. What? Some type of insulator, right? Some type of barrier for electron flow, right? So what we see is in the heart, there's just connective tissue separations that separate these cells along the conduction pathway. So as long as we have connective tissue separations, it's forced along that pathway. Do we ever see impulses go off of the conduction pathway and all of a sudden we see the heart fire outside of the SA node? Yes, we do. We have what's called premature ventricular contractions, or PVCs. Those of you that had lab already know what that is, but those of you that haven't, we'll talk about it. And those are just extra firing of the heart. Sometimes people get this, what is called as an ectopic focus. They have a cluster of cells outside of the pathway that are firing a heartbeat. And the heart is beating abnormally and has an abnormal rhythm. Maybe it's beating faster than it should. And what we have to do then is kill those cells. That they actually run a wire up through the femoral artery in over the surface of the heart, and then they cauterize those cells that are causing problems. It's called a cardiac ablation. Have you ever heard of the word ablation before? So that's how they take care of these extra little impulses that are sometimes generated around the heart. So just keep in mind that it's connective tissue separations that force this action potential on this pathway. Now, if a person has a heart attack and muscle cells on the conduction pathway are damaged due to lack of blood flow because of a blood clot, can that lead to irregular heartbeats and rhythms, do you think? Yeah, and it happens. So how do we fix that? We give people a pacemaker, right? That it externally stimulates those ventricles to contract. So let's talk about this extrinsic innervation then. So we know the heart can respond to external factors that are generating action potentials outside of the pathway, right? We know we use an AED, right, to get people to zap them into life if their heart is stopped for some reason. So where does this, if we're looking at just the nervous system, where does the impulse start? And that's in the brainstem. The medulla is where the part of the brain that generates the action potentials to control heart rate, that's where it all begins, is in the medulla. And we know cardiac muscle is part of what nervous system? Somatic or autonomic? It's part of the autonomic nervous systems. And the two divisions of the autonomic nervous system are sympathetic and parasympathetic. So if we look at these nerves leaving the spinal cord and synapsing on heart muscle, the blue represents the parasympathetic nervous system and the green represents the sympathetic nervous system. Are there any differences in how they stimulate the heart? Well, we know that the parasympathetic will do what to the heart? It's part of what system? The rest and digest. So what would you expect it to do to the heart rate? Slow it down. And then the sympathetic would speed it up, right? But if we look at this, the fibers of the sympathetic neuron here is shown in green compared to the parasympathetic fibers shown in blue, we can see that the sympathetic vagus nerve here, this is just a branch of the vagus nerve, comes down and synapses on the SA and AV node. So the parasympathetic nervous system can only control the heart rate. Would you agree with that? Because it only innervates at the SA and AV node? Yeah. The sympathetic neuron here, if we look at that, that does the same thing, SA node, AV node, but it also has fibers going to the cardiac muscle itself. And it also has fibers going to the coronary arteries. So if I think about that, if I stimulate the sympathetic nervous system, a stress, remember fight or flight, so I've got a bear here, I'm going to either fight the bear or I'm going to run from the bear. Either way, my heart needs to enable me to do either of those activities, run or fight. So what would the sympathetic nervous system do to the SA and AV node? Speed it up, increase the rate of action potentials going to the SA and AV node. How about the heart muscle itself? Those contracting cells, what would we want to do with those contracting cells? Increase the number of cells that are working together to contract the heart, right? So it increases a concept we call contractility. And the word contractility refers to the force of contraction. So how hard my heart contracts. So would you agree if someone has a good amount of contractility, more blood leaves the heart per beat than someone who has a low contractility? Yeah, more blood remains in the heart. So that's what heart failure is. Heart failure patients have low contractility, and as a result, their ventricles can't eject all the blood that they need to feed their tissues, and then blood starts to back up, and then the heart fails. So contractility, and then what do you think happens to the coronary arteries then if the sympathetic neurons are firing on this heart? Dilate, because we want good blood flow to this hard-working heart, right? So the coronary arteries would dilate. Again, think of stress has S's, sympathetic has an S, and you're fighting or flighting. Think of how the heart would need to support a fight or flight response. Okay, so this is all coming from the medulla. Now, can we override the medulla? We talked about the nervous system before. Can I override what the medulla is inputting to my heart? Can I think about something and lower my heart rate? For sure. That's what yoga and meditation is about, right? Biofeedback. Definitely. So I can override those thoughts or those processes with my thoughts. Same thing. Can I increase my heart rate? Definitely, right? Stress can do that. Negative thoughts. Excitement, right, can do that. Love can do that. Oh, one more thing I want to talk about. There's an interneuron, where is it? Oh, right there, okay. That, notice that that's coming from the medulla, the top structure, and then we have an interneuron. So we also have an ability for the heart, or the medulla, to impact the heart, and that feedback to go right to the medulla again and cause a reflex. We know that we have sympathetic, right, autonomic reflexes we talked about, so that can happen, that overrides the brain and the hypothalamus. So we'll talk more about that when you get into the more advanced concepts of the heart. So an EKG then is what we're talking about in lab. So I'm not going to spend a lot of time talking about it in lecture, but just be aware that the P wave tells us that the atria are depolarizing and getting ready to contract. So depolarization of the atria, that little bump of the P wave, happens right before the atria contract. So if the atria are functioning at the SA and AV node, we should see a deflection here from the horizontal, which is the P wave. And then shortly after that, as that impulse goes down the interventricular septum and up the Purkinje fibers, we should see this nice, tall, narrow QRS complex, which represents ventricular depolarization. And the atria are repolarizing during this time, but that's buried inside the QRS. And then after a short period of time, we see ventricular repolarization. So if we look at the action potential, now remember the contractile cell's action potential. That's 99% of cells in the heart, right? What's happening, what is happening during this contraction or this depolarization and the repolarization? There's this little delay, there's this ST segment. What's happening there on the action potential? Can you remember what the action potential looked like? Yeah, exactly. That's when the plateau is occurring. So it comes up, potassium channels start to open, but calcium channels open as well. It flattens that curve out, and then potassium continues to flow out of the cell and we repolarize. So this ST segment, what's going on right here is that plateau due to calcium entry from the outside. Yes? The plateau would be after the ventricles contract. So we have full contraction and then relaxation. So it kind of just spreads out that action potential. Okay, so this is a nice little step-by-step guide of what's going on in the heart at each point in the EKG. So we just talked about this area here. Depolarization is complete. We have that plateau. And then repolarization is when that potassium then is flowing out of the cell, right? And then we start over again. So we're going to talk about the different types of EKGs that we see when there's different problems going on within the heart. For example, if the atria were not contracting, they shut down because of some problem, some damage along the conduction pathway, and only the ventricles were working, what would be missing? The P wave. We would see no P wave. We would just see the QRS complex. And then because the action potential going down to the ventricles is much slower, also, we tend to see that when the ventricles are the only thing that are working, it really widens the QRS complex without the input of the atria. It's a much wider complex, and you'll see that when we get to lab. So here's just some examples. See the junctional rhythm there? The SA node is non-functional. There is no P wave. So the heart is paced by the AV node, going at 40 to 60 beats a minute. And fibrillation in the lower right-hand corner, that's the really dangerous one. That means the heart is quivering. But again, we'll talk more about that in lab, so I'm not going to spend a lot of time about that here. So let's talk about the heart sounds then. So when you first assess a patient, looking at their cardiac function, you're going to listen for the sounds of those heart valves. And where are the valves located in the heart? Do you remember? Yeah, between the atria and the ventricles are the two AV nodes. So we had the left and right AV nodes. And the way to remember is a lot of people use their own individual names. So on my left, I put my hand over my left side of my heart, right, is how I remember it. And that's the mitral valve, all the my's. My left side is the mitral valve. So the left AV is the mitral valve. That's another name for it. And then the right is the tricuspid valve. And I just remember it as right has an I and a T, and tri has an I and a T and an R. So right is the tricuspid valve. So those are the two AV valves. So if we look at the cardiac cycle, we can see when these valves close. And then the other valves are at the base of the two major arteries leaving the heart. And where are those located? The aorta and the pulmonary artery. So that's where those two semilunar valves are located. So if we look at where I would put the stethoscope, that's what the circles represent. So the vibration of those valves as it goes across the chest wall kind of spreads out a little bit. And you're not expected to know that. I work on a cardiac floor, and I don't even need to assess valve functions. We just need to assess, is there a murmur present or not? We don't have to look at individual valves. This would be for an advanced practice nurse or a cardiologist or a physician's assistant who works in cardiology. That's where they really need to know their valve locations. But for where you're going with here at Western, you don't need to know that amount of detail. But to understand the valve function, you really have to understand the cardiac cycle. So we're going to kind of examine every step of the cardiac cycle and then apply that to the valve functions throughout that process. So two words you need to be familiar with. Systole. When you read it, it looks like systole. That's what I thought when I first read it. But it's systole. And the other one is diastole. So systole means contraction, and diastole means relaxation. So maybe you've heard, if you watch Grey's Anatomy, right? Netflix, it's the big thing. All the young people are watching. My daughter does. He's asystole. A means not contracting, which means heart is not contracting. There's no pulse, right? So systole. And you've heard of blood pressure, systolic blood pressure over diastolic. The top number, 120 over 80, is the pressure when the heart is contracting. That's the systolic. And the 80 millimeters of mercury is the diastolic. It's the pressure in the arteries when the heart is relaxed. So looking at each phase of the cycle then, your textbook has a nice diagram here. Somewhere. Cardiac cycle. Where did it go? Is that in the old book? Figure. Okay. Yeah, this is not a fantastic diagram. It's 1819 in the current edition, which is the 10th edition that I'm looking at, page 686. So the first part of the cycle is when blood is returning to the heart through the two major vessels. What are the two major vessels returning blood to the heart to be oxygenated? Yeah, superior and inferior vena cava. So we have those vessels bringing blood into the right atrium, and then on the left side of the heart, where's blood coming into the left atrium from? Pulmonary veins, right? Veins always bring blood to the heart. That's a hard and fast rule. Veins carry blood to the heart. So we have this ventricular filling going on. So the blood is coming into the atria, and it's going right to the bottom of the atria and going through open AV valves. So this is passive, wouldn't you agree? It's just coming in through the veins and coming into the atria and going right into the ventricles. So 80% of that blood in the ventricles happen passively. So here's my, two atria. Let's say this is a ventricle here. So it's just passing right through my atria into the ventricle. So 80% of that. I'm going to use this for a different demonstration. But then the SA node fires and the atria contract, and that fills the remaining 20%. So most of the heart fills passively, and then the atria contract. So there's a volume that we can measure. It's called end diastolic volume, which means how much is in that ventricle at the end of this period of relaxation of the heart. We call that end diastolic volume. And the value of that number is about 120 mils. Then the ventricles contract. So they're filled 80%. The atria contract with the firing of the SA node, fills the remaining 20%. Now the ventricles are filled 100% of the blood that was returning for that cycle. And then the ventricles contract. So that pressure rising, the key thing is number 2, the rising pressure in the ventricle pushes on those AV valves that were open and closes them. That's the first heart sound. So next to bullet number 2, you might want to write, that's the lub. When you listen to someone's heart rate and you hear lubbed up, lubbed up, lubbed up, the lub is right at the beginning of ventricular contraction when that pressure of blood in that ventricle pushes against those valves and closes them shut. So that's the lub. Now no blood has left the heart yet, so that's a very brief period where the AV valves close, pressure in the ventricles is rising, but there's no ejection of blood yet. So we hear the lub before blood actually leaves the ventricles. So we call this phase the isovolumetric contraction phase. Iso means same. Volumetric, same volume, which means that the volume isn't changing. We're not adding blood to the ventricle. There's not blood leaving the ventricle. It's static for just a brief moment when those AV valves slam shut. Then, as pressure continues to rise, as my ventricles squeeze even more, that pushes the semilunar valves open at the base of the aorta and the pulmonary artery. So we call that the ejection phase, but that's when the pressure in the ventricles has to be larger than the pressure in the pulmonary artery and the aorta to force those semilunar valves open. And then blood starts to leave. So we call that the ejection phase. So at the end of that contraction, there is some volume of blood left in the heart. And the volume for that is the ESV, end systolic volume, which means at the end of contraction, how much is left in the heart. We should have pretty much squeezed a lot of it out, right? But we find that there's about 50 mils left in the heart. So with that information, if there's 120 mils, if I pour this here, it'll be close enough. So if I fill my beaker with 125 mils of fluid, this is my end. Which volume is 120 mils? At the end of relaxation, right? Filling. I just did my filling, right? That was the superior vena cava, inferior vena cava, and pulmonary veins doing their filling of each of the ventricles. And I have 120 mils. And then I eject, how much? What? Well, that's what we're trying to figure out. So how much did I say was left when we're done? 50. So that's what's left after. So I started out with both of these. At the end, this is what I had left in the heart. So then I can say, what did I actually eject from the heart, which would be what? 70. So we call that number our stroke volume. We'll talk about that in a little bit. So just keep those two numbers in mind. So at the end of contraction, there's a little bit of volume left in the heart. Then the ventricles relax. And for a short period of time, all of those valves are closed again. So at the end of ejection, the blood wants to flow back toward the heart through the pulmonary artery and aorta. And that causes those valves to close. So that's the dup that we hear when those valves close. When the heart relaxes. So we're not going to see the dup until the ventricles have relaxed. So the backflow of blood in those arteries going back toward the heart shuts those valves, and that's the dup. So we have lubbed up, lubbed up, lubbed up, and I'll show you an animation of this too. And then as that blood flows back toward the aorta, or toward the semilunar valve at the base of the aorta, we see a brief rise in aortic pressure just because of it kind of splashing backward on that semilunar valve, so we'll see that when we look at the graph. But again, we have another isovolumetric phase, but the heart is relaxed. But the reason why we call it isovolumetric is because all valves are closed. So So whether you're in the isovolumetric contraction phase or the relaxation phase, all the valves are closed. That's the key thing. So here's the graph that's shown in your textbook. So it shows you on the bottom what's occurring in each phase. So if I look at this diagram, we have ventricular filling to start things up, right? 80% of it is passive. Atrial contraction fills it another 20%. And then we have that brief isovolumetric contraction phase, which is just before which valves open. At the end of this phase, which valves open? The semilunar, right, because we're going to eject that blood from the heart and send it into those arteries, which is the aorta and the pulmonary artery. Then the heart is relaxed. And for a brief period of time, all the valves are closed, and that's that isovolumetric relaxation phase. And then ventricular filling again happens. So what opens the valves? Is it changes in volumes or changes in pressure that opens the valves? Changes in pressure, yeah, on one side of the valve compared to the other. So that's a key thing to take note of, is changes in pressure. So the difference between the end diastolic volume, which is shown here, so at the end of relaxation, just before the ventricles contract, we said that was 120. And then after they contract, there's 50 mils left in the heart that didn't leave for contraction. The amount that leaves the heart with every beat, we call that stroke volume. So that's what the SV stands for. It's just the difference between my end diastolic volume and my end systolic volume, which is about 120 mils. I'm sorry, 70 mils. 120 minus 50, which is 70. So 70 mils is what leaves the heart with each beat. So if I have heart failure, do you think 70 mils do I have enough contractility to push that 70 mils out? No. What would happen to my end diastolic volume, do you think, if I have heart failure? It's going to be higher, yeah. How about my end systolic volume? It's the systolic volume that leads to the end diastolic volume. Let's talk about it. Maybe I jumped too fast. Okay, so I've got a weak heart. It's not contracting fully. So if I had a really good contracting heart, at the end of contraction, I should have 50 mils, right? But now what I'm saying is if you've got a weak heart, it can't contract completely. It can't get rid of that blood. So I might have, instead of 50 mils at the end of my end systolic, I might have 70 mils. So is that then going to lead to failure and stretching of the heart muscle? Definitely, because blood is backing up, because I still have filling going on, right? If I have good pressure, I still have filling happening, but now I've got extra blood left over. So what is that going to do? That's going to stretch the heart. It's going to stretch it out, and then it's going to try to contract. And initially, the heart can contract because it tries to keep up with the sympathetic nervous system and trying to keep up with the volumes. That works for a while, but then eventually the heart fails. And then the heart gets bigger and stretched out. And we call, when the heart is getting bigger in size, we call that hypertrophy. It's the same term we use when a person does bodybuilding and they're lifting weights and their muscles are getting bigger. We call that hypertrophy. An increase in size, we call that hypertrophy. So the heart starts to enlarge as a result of that backflow of blood that we see in heart failure. So if we look at some other things going on here, so if I look at my EKG, we know that the atria contract right after they depolarize. So I can see here's the bump showing that this is a pressure reading here. I can see that my atria are contracting, and there was a P wave just prior to that. And here I can see my ventricles were contracting, and there's the QRS wave. And notice right at the end of ventricular contraction is where my heart sound came in. Because at the end of contraction, right, is when this is the depolarization. At the end of depolarization is when the contraction occurs, which is going to shut those AV valves, right, for my heart sound. And then the heart relaxes here. We can see the T wave indicating relaxation of the ventricles, and that's when my second heart sound appears because the backflow of blood on those semilunar valves. So this graph really shows a lot of information, and this just shows pressure in the different chambers. Here's that notch that we see. So we have rising pressure in the aorta, and then it drops and bumps back up again as that backflow of blood on the semilunar valve at the end of ventricular contraction causes a dip in pressure there before it rises again and then drops off. So this is just showing us the volume. This black line is showing us the volume in the ventricles throughout the cardiac cycle. So here we know that we have filling occurring, right? So we see the volume increase. And then as blood is ejected and the ventricles are contracting, we see a big drop. And then we see filling occurring again here. So if you look at this graph, you should be able to identify the different things that are happening throughout the cycle in terms of the EKG and the heart sounds, pressures in the chambers, and volumes of the ventricles. So this is something that kind of sums up a lot of what's going on in the heart in a visual way. Oops, I want to show you this tutorial here. So what's nice is you can kind of stop this as we go through here. Okay, if we go back just a step. Oop. This is that isovolumetric contraction phase. So if you can see where we are on the graph as well. So that's what shuts those AV valves, right? So if I have a funny sounding lubbed up, if it has kind of a lubbed up, then I know there's a whooshing of blood going backwards into the atria. And that's why we listen for murmurs, because it's telling us what's going on in terms of valve function, and then people need to get valves replaced very commonly. Which valves do you think are most at risk for needing replacement? Which side of the heart endures the highest pressure? The left side of the heart. So what two valves are on the left side of the heart? The mitral valve and the aortic valve. Yeah. So over time, even in healthy people that take care of themselves, sometimes the heart valves just wear out. And as a result, they need to get it replaced. And sometimes they'll use a Pig's valve. They call it a porcine, P-O-R-C-I-N-E, porcine valve, or a mechanical valve, which is artificial material. But whenever you put something artificial, like a mechanical valve, into somebody, that has a risk for an immune reaction and for you to form clots. So people that have valve replacements, they need to go on blood thinners because they're at risk for blood clots that could cause heart attack or stroke. And we have to really monitor their coagulation studies, looking at INR and PTT and things like that. So you've heard of Coumadin or warfarin that people take, maybe you have or haven't, and there's newer ones out there, like there's one that starts with an E. I forgot which one that was now. What is it? An Enopril? I'm not sure. I don't remember. Oh, shoot. It slips my mind. What is it? Eliquis. Thank you. Thank you. That's it. Yeah, so there's a lot of newer ones. And some of those we have to be careful with, though, because they'll say, oh, you don't need to come in for any lab studies. You don't have to do this constant checking of your coagulation levels. But that's kind of scary, because if that medicine would fail, a person could die of a heart attack or stroke. They could have major clot issues, or they could have too thin of blood and be at risk for a brain bleed with a simple bump. So it's kind of scary to try those new medications when they don't ask you to look at labs. So it's something to just keep in mind. But anyway, so if you look at this tutorial, it really goes through all the different phases, and just try to make yourselves comfortable kind of what's going on in terms of volumes and when the valves are closing, so you have a feeling of what's going on in the heart. And then a good understanding of that is going to help you with the next part, which is looking at measurements that we take of the heart. And this is in the next set of notes. Uh-oh. Okay, so now that we know about the electrical system, basic heart functions, the cardiac cycle, we'll talk about some measurement properties that we do to look at the heart. So first concept is cardiac output. So it's the volume pumped by each ventricle in 1 minute. So we talked about these volumes that I have. So it's the volume pumped by each ventricle in 1 minute. So would you agree that the faster I emptied this beaker, the more blood would leave the ventricle in a minute? Right? Yeah, definitely. Okay. And then the stroke volume, so the more I pour out of the beaker, out of the heart, the more blood that leaves the heart, the higher the cardiac output as well, right? So if a person exercises and they have really strong heart, because the heart gets stronger, the contractility increases when we challenge our heart. Like any muscle, the heart is a muscle, right? If I want to get a stronger bicep, I just lift weights and I work that bicep. The more I work it, the stronger it gets. The same thing happens with the heart. The more I beat that heart hard, like with exercise, because I see some people on the treadmill at the Y and they're just walking along, and you know, they're burning some calories, better than sitting, right? But they're not really getting any cardiovascular benefit when they're just walking along. Or even if you take your dog for a walk, you know, say, oh, let's take the dog for a walk, get some exercise. But you're not really breathing hard and your heart isn't really beating, you're not getting the cardiovascular benefits. You're getting the fat burning benefit, you know, but you're not getting that cardiovascular. So we need our heart to beat hard, not really hard to where you're gasping for air, right? But reasonably so. So you can feel it. Then the heart has a higher rate of contraction. So what would that do to stroke volume if I had a more conditioned heart? What? It would increase. It would increase. So I would have, you know, more blood leaving the heart with each beat. So stroke volume is the amount of blood that leaves the heart with each beat, and cardiac output is what leaves per minute. So what happens if I have a really efficient heart that can pump a lot of blood in one beat, has good stroke volume? What will my heart rate have to be in response to maintain cardiac output? What? Lower, yeah. So if I have lesser blood leaving the heart, a weaker heart, initially my heart rate's going to speed up to try to counteract that. So we see that in healthy people. After a while, then the nervous system kind of adapts when we have chronic conditions. It no longer will try to speed up the heart. It'll just kind of get a new set point. And that's where you have a broken feedback system, right? Negative feedback is broken. But in a person with dehydration, for example, if I'm dehydrated, do I have lower blood volume? Yes. So I would have lesser stroke volume. My blood pressure would drop. All of those things work together to increase heart rate. Wouldn't you agree? We would see an increase in the heart rate as a result of that. Okay, so when we're calculating cardiac output, then you need to have two pieces of information. The heart rate and the stroke volume will tell us the cardiac output, because it's a per minute calculation, where stroke volume is just how well that ventricles, how well they eject their blood with each beat. So that does not depend on heart rate. So at rest, when we're just hanging out, we're going about 75 beats a minute for our heart rate, and we know stroke volume is about 70. We should see a typical cardiac output. I mean, the amount of blood that leaves the heart every minute is about 5¼ liters per minute. And this is in every A&P textbook. It's a little gender bias. It's always a healthy adult, young male, about 21 years old. So as we age, of course, that number would be less, right? So if you are well trained, it can be as high as almost 7 times larger than you're resting. So that's a lot, you know, of blood serving the muscles. And if your heart is well trained, it can have a very efficient stroke volume, and you don't see as high a heart rate. If a person's really in bad shape, they get, you know, really, they top out. They have maximum heart rates. Isn't that going to affect your cardiac output? Your maximum heart rate? Yeah, and that depends on age too. But the more conditioned we are, the less, like I say, your heart has to beat to get that efficient stroke volume or cardiac output. So the cardiac reserve is the difference between your maximum cardiac output with exercise and what it is at resting. So cardiac reserve, who has a higher cardiac reserve? An athletic person or a couch potato? Obviously the athletic person, yes. Not the couch potato. Okay, so things that we can do to regulate, that the heart does, or conditions in the body that can affect the amount of the amount of blood leaving the heart. There's 3 factors. So we're talking about how much can leave per beat, stroke volume, right? So we have preload. We already talked about contractility, right? The harder the heart contracts, the higher the stroke volume. And then afterload and preload. Those are 2 concepts that can be a little tricky, so we'll talk about each. So preload is the degree of stretch of the muscle cells before they contract. So we talked about if your heart is starting to fail, it starts to stretch, right? And it starts to get bigger. Well, we know with skeletal muscle that if I bring my heart a little bit beyond, or my muscle a little bit beyond resting length, I can get a larger force of contraction because I have more actin and myosin filaments interacting and pulling them toward the center, right? So when we have a little bit of stretch of the heart, that can give us a little stronger of a contraction and a higher stroke volume. So at rest, cardiac muscles cells are shorter than the optimal length, but as we exercise and we have more blood coming in, would you agree that that would stretch the heart out a little bit more beyond its resting length? Okay, so we call that preload. It's preload, meaning it's what the heart has to overcome to contract. So the more blood that's in my heart, the higher the preload. Would you agree? You know, the before contraction, the load I have to overcome before it contracts is preload. So we use the concept of venous return, which is blood coming in from where again? Where? Which veins are coming into the heart? Pulmonary veins and the vena cava. Yeah, superior and inferior vena cava. So venous return, if I have increased venous return, that brings more blood into my heart, into my ventricles. Remember, 80% is passive. It stretches those ventricles out a little bit, and we call that amount of stretch preload. So if I have good venous return, I have a higher preload, a little more of a stretch, and then when I contract, more blood can leave the heart. Make sense? So what increases venous return? I'll talk about that. I think that's coming up. I should look at my PowerPoint. Do we have is there something that talks about increased venous return? I think that was part of your blood vessel chapter, actually. So let's refresh our memory of that. What helps bring blood back to the heart? A couple of different things. One is muscle contraction. So when you stand up, if you're sitting and sitting and sitting, or you're laying and laying and laying in the hospital all day, that's not good for venous return. It sits in your large vessels in your extremities. So we tell people to get up every now and then. Even if they're too sick to walk to the bathroom, we say, let's just stand on the edge of the bed, right? Or if they can't even do that, they're comatose, we put the sequential compression devices on their legs, right? And these kind of squeeze and release, and that gets venous return, pushes that blood back to the heart. So that we do it that way. Another way we do it is by deep breathing. When you take a deep breath, what happens? Your chest cavity expands and your abdomen goes in, right? And the abdominal volume decreases. That increases venous return through the inferior vena cava that runs through the middle of your body, right? In your abdomen. So that increases venous return. So deep breathing increases venous return, and muscle contraction increases venous return. Those are 2 things. So if a person is exercising, would you agree that both of those things are happening? Yeah, and that's going to increase venous return. And again, so venous return is going to stretch out those ventricles, and it's going to increase our preload. Contractility we already talked about. It's just, how hard that muscle contracts. So some things that we have going on in the heart, in the extracellular fluid, is if we have increased calcium coming into the cell because we're stimulating with the sympathetic nervous system, increased action potentials coming to the heart, that's going to increase the calcium inside those cells. And certain hormones, we know epinephrine, right? That's part of the sympathetic nervous system. That's secreted by that postganglionic neuron, right? Right onto the receptors of the heart. What other names are the receptors that respond to epinephrine on the heart? Because you might see that question again. Beta 1. Beta 1 receptors are going to respond to epinephrine, which is going to increase contractility. And then glucagon and thyroxine also increase contractility of the heart. And things that slow the heart or decrease, weaken the heart, calcium channel blockers. Do we ever want to give someone a calcium channel blocker? Yes. If they have high blood pressure, do we want them to have a hard contraction into those narrowed vessels? No, we want to slow down, block that response a little bit. So we give people calcium channel blockers as a blood pressure medication. That's one class of blood pressure medications, are calcium channel blockers. Increased extracellular potassium, we talked about that already, right? And acidosis. All of those are negative factors that slow down or decrease contractility. So that's going to decrease stroke volume. Then afterload is the pressure in the vessels that the heart has to overcome to get the blood out of the heart. So the preload is what it needs to get started contracting. You know, that's the stretch of the heart. And then once it contracts, what it has to overcome to eject that blood is the afterload. So key thing that affects afterload is blood pressure, the pressure in the vessels. If I have narrowed vessels due to high cholesterol and plaque buildup, that's going to lead to hypertension, which is going to be a larger force for the stroke, for the heart to overcome to get a decent stroke volume. So again, trying to simplify things, a major factor affecting preload is, in a healthy heart, very good, venous return. And a major factor affecting afterload is blood pressure in the arteries, right? Arterial blood pressure. So if we have high blood pressure, which we call hypertension, that's the clinical term for blood pressure. High blood pressure is hypertension. And we abbreviate it in the clinical paperwork as HTN, means high blood pressure. That's going to cause an increased end systolic volume, right? So the volume left in the heart after it contracts is going to be higher because there was so much pressure to overcome. We couldn't completely empty that ventricle with the contraction. And then we're going to see less leaving as a result, so lower stroke volume. So the nervous system helps to regulate some of these factors affecting the heart. So like I said, the sympathetic nervous system affects the pacemaker and it affects the heart muscle cells, right? So it causes increased contractility and heart rate. And we talked about the parasympathetic nervous system slows down. And remember, acetylcholine is the neurotransmitter of that postganglionic neuron. And what type of receptors does it bind on the heart? Do you remember? What type of receptors are on the heart that respond to the parasympathetic postganglionic neuron, and specifically the transmitter is acetylcholine? And it causes a slowing of the heart. What? Muscarinic, very good. Yeah, so that is going to hyperpolarize, because that when acetylcholine binds to muscarinic receptors on the heart, it causes potassium channels to open. What type of potassium channels? What? Yeah, I hear somebody saying it. Is that you saying that, Macy? Back there? Okay, yeah. Yeah, ligand-gated, because acetylcholine binds, opens up those channels. So it's a chemical that causes it to open. Okay, so that is how we can overcome if we have too much sympathetic stimulation. Parasympathetic nervous system is going to bring that down. But at the same time, we talk about that vagal tone. Remember I said the SA node is at 100 is where the automatic intrinsic action potential generation is set, and the parasympathetic slows it down to 75. So this is that concept. So just remember, it goes from 100 to 75 because of vagal tone. Why do we call it vagal tone? What is that referring to? Yeah, the vagus nerve. Okay, another thing when we look at reflexes, the Bainbridge reflex, is the stretch of the atrial walls automatically causes a stimulation of the SA node. So it causes a loop back to the SA node and causes contraction. What would be the benefit of that? To connect the receptors in the wall of the atria to the SA node via a reflex arc. Well, if the atrial walls are stretching, do we want that to continue? No. What's the only way to get the blood out of there? To contract the heart, right? So the more stretch I have, I'm going to stimulate an action potential. I'm going to contract the heart. So think about, kind of put that in order. What is the benefit to the heart to have that input like that? And that is to keep the heart from overfilling with blood. So that's the benefit of that. So increased stretch of the atrial wall is going to fire the SA node, cause contraction, and get that blood out of there before it overstretches the heart and does damage to the heart. So what increases that reflex? What fills the heart? What is the concept that fills the heart? Venous return, right? The more venous return I have, the more often I'm going to fire that reflex, right? Which is going to cause contraction. Again, so it's just an amazing machine, I think, when you look at all these factors, how the heart is wired to protect itself, because it is the main, organ outside the brain to control and get nutrients and oxygen to all of our tissues. So this is just a nice little flow chart that puts all these concepts together. And you can see how cardiac output with exercise influences venous return, contractility, those end diastolic and systolic volumes, and then the hormones. So just a little visual. So chemical regulation, we already talked about that. Epinephrine comes from the adrenal medulla. Remember that, right? That's the sympathetic nervous system. That's going to increase heart rate and contractility. And we also know that the hormone thyroxine from the thyroid gland increases heart rate, and it enhances the sympathetic response. So if a person has hyperthyroidism, they have an overactive thyroid, what's a symptom of that going to be? Yeah, increased heart rate, potentially increased blood pressure, because that has a direct influence on the heart. And then again, we have to really watch those calcium and potassium electrolyte balances for its effect on the heart. We talked about that excess potassium is going to slow the heart and can be dangerous. Other things that affect heart rate, age. The older we get, what do you think happens to heart rate as we get older? Slows down. So when you test the heart rate of a 85-year-old and it's only 55, it's not because they're in great shape. Right? It is if it's a 25-year-old, right? But not for an 85-year-old. The problem is we need to get the heart rate up for some of those people. Babies and children have a much higher heart rate, right? Gender, men versus women, who has a higher heart rate, do you think? Women do. Women do. Exercise, obviously, does what to the heart rate? Well, when you're exercising, right, it increases. But then if you're a regular exerciser and we check you when you're resting, it lowers. And why does it lower? Because you have a higher stroke volume and contractility, right? Level of contractility. And body temperature. I can always tell with my little kids when they had ear infections and a fever, I could tell by this. I noticed this right away also. Increased heart rate with a fever, right? Because the body's working harder because of the fever, elevated temperature, so that's going to require more oxygen, so the heart responds by supplying more oxygen through a higher, faster heart rate. So blood pressure is really important to keep our tissues served with oxygen and nutrients. So which is more important to the body, do you think? Fixing a high blood pressure or fixing a low blood pressure? What do you think there's more controls in place intrinsically in the body for? High or low? Which one is going to kill you faster, do you think? I heard both answers. A low blood pressure is going to kill you faster because you're not going to get oxygen and nutrients to your tissues. You're going to pass out, right? We have, what, a couple minutes before we pass out without oxygen to the brain? You're done. High blood pressure, we can dilate vessels and you can tolerate that for a while. That's why we call high blood pressure the silent killer. Some people are walking around with blood pressures 170s, 180s as a systolic top blood pressure number, even in the low 200s, and they don't even know it. And that goes on for years. What does that do to contractility over time when there's that amount of pressure, you know, with contraction? Fails, right? So anyway, it's a silent killer. So there's more controls in place for a falling blood pressure than there is for a rising. So we're constantly looking at these three factors. We talked about cardiac output, blood volume. Well, what are the two components of blood? What are the two components of blood? If I spin your blood down, what are the two major components? We've got the formed elements, which is red blood cells, white blood cells, and platelets, and then we have the plasma. So those are the two components. What do we have control over on a day-to-day basis? Which component? The plasma, because the plasma is mostly water. So we can control the plasma volume by doing what? Drinking fluid, yeah. So the more fluid we drink, the more gets absorbed into our blood and stays there if we need to maintain a blood pressure, right? So we can control that blood volume a little bit with how much we eat or how much we drink or how much fluid is in the foods that we eat. So this is really important for people with heart failure. Sometimes they don't get that concept, right? Because they didn't take advanced A&P. And they have a failing heart with too much blood at the end of contraction and they're drinking fluid all day. Where's that fluid going to go? Especially if they have failing kidneys that are not able to filter the blood out and they're not peeing it away. It's staying in the blood vessels. And then if it can't even stay in the blood vessels because it's so full, it squeezes out of the capillaries into the tissues, and we call that edema. Okay. So cardiac output, blood volume, peripheral resistance. So it's resistance outside the heart. Something, you know, is resisting the flow outside the heart in the periphery. So what would cause that? What would cause an increase in peripheral resistance? Yeah, blocked vessels with cholesterol, right? If I have clogged arteries, that's going to increase my peripheral resistance. Or if something happens in the body that causes my vessels to all constrict, that can cause increased peripheral resistance. So the diameter of the blood vessels, right? Okay, so if we look at changes in blood pressure can be affected by cardiac output multiplied times the resistance. So how much blood is leaving the heart versus how much is pushing against that blood leaving the heart, right? So they're kind of two opposing factors. Cardiac output is leaving the heart. Resistance is resisting that and preventing, and that's that afterload we talked about. So we already talked about those concepts, so I'm not going to go into this again. But if I look at a decrease in blood pressure, so we're going to work from the top down rather than from the bottom up. So if I have a decrease in blood pressure, the medulla has the receptors that are constantly sampling the environment, pressure receptors, right? Baroreceptors we call these, that detect pressure changes, saying we got a problem, we need to fix this. So if pressure is falling, we know that the sympathetic nervous system is going to do what? Increase the heart rate, increase the contractility, and that's going to raise blood pressure, right? So that's one thing that would happen is we're going to stimulate the sympathetic neurons going to the heart, and we're going to inhibit parasympathetic neurons going to the heart. And if I increase sympathetic activity, that's going to release epinephrine to the blood. Remember we talked about how epinephrine kind of hangs around for a while, so it has longer effects. So that's a good thing, get that epinephrine in the blood. And that epinephrine is going to bind to those contractile muscle cells and cause an increase in contractility. And that's going to lower my end systolic volume, right? Because I'm going to get more blood out of the heart, which will increase our stroke volume. And we're going to increase the heart rate as well, which is going to increase the cardiac output. So I've created more of a push, right, on my pressure control to increase blood pressure. Now, I can't necessarily overcome resistance, right? If the arteries are clogged and blocked. I can't fix that, but I can do all of this. So if a person has high blood pressure due to constricted vessels, is it good to have increased sympathetic activity going on all the time in the heart? No, that's bad for the heart, right? So we know that we need to fix that over time, sometimes with medications. And a lot of those medications block the sympathetic response. So we need to control the blood pressure, but yet keep the heart rate up, obviously. But if we have narrowed vessels, another medicine that we're going to give is one that opens up the vessels. Some are very powerful vasodilators, so they open up those vessels and allow that blood to flow. And some things that we give for a kind of a rescue situation, we don't want people walking around popping these like sweet tarts, but what's the powerful medicine people take under their tongue that opens up vessels to overcome resistance? Nitro, yeah. So they put nitro under the tongue, it dissolves, and that opens up the vessels over the heart and makes them feel better. But that's a quick fix. We want to make sure we figure out what the bigger issue is. But there's other ones that are called pressors, vasopressors. Have you heard of that? Does anybody work in the healthcare environment that you've heard of those before? Vasopressin, yeah. That's something that opens up the blood vessels, relaxes the smooth muscle of the vessels, and overcomes resistance, and then as a result of that, you're going to have a decrease in blood pressure. All right, we talked about venous return, and here's just a review of those two things that I said will increase venous return. Remember, I said the respiratory pump, so when you take a deep breath, that change in pressure, it increases pressure in the abdomen, decreases in your chest, and brings that blood back to the heart. And the skeletal muscles. As I work my large muscles of the legs, there's deep veins in there that are squeezed by those pumping actions of those muscles, which is going to increase venous return. So do know the factors that affect venous return, because remember, veins don't have a thick muscular wall like arteries do. They don't have a heart pumping that blood back to the heart because we've got the capillary bed. And the pressure after the capillary bed is low because it's only on the arterial side that we see this increased pressure. So this is in the wrong spot there. I don't know how that happened. That's strange. So the baroreceptor reflex, baroreceptors, what did I say they control? Pressure. So baroreceptors are constantly sensing pressure changes. So where do we have these baroreceptors? You should highlight this. I know it's really tiny on the note packet you have, but number 2, in the carotid arteries and the aortic arch, we have pressure receptors. So in the carotid arteries and the aortic arch, 2 major arteries, we have pressure receptors that will provide feedback to the medulla to stimulate the heart if necessary. So if I have dropping pressure, for example, and this happens among young people, you're laying down watching TV and the phone rings, or now we have cell phones, we can lay there, right? The dog barks or someone comes to the door. How about that? We leap up and woo, you feel really dizzy, like you're almost going to pass out, right? That's because when you're laying flat, the pressure changes and the blood flow to your brain is a lot quicker because you're laying flat, so your carotid arteries are more dilated. But as you stand up, that changes, right, very quickly, and then you don't have enough blood flow to the head, and the carotid the carotid receptors for pressure in the wall of the carotid arteries respond and stimulate the heart to increase the heart rate, constrict the vessels, and get that blood going up to your brain a lot faster. So some people are not very good at that, but as we get older, that tends to get better, but then it gets worse again as we age. So that's why we take orthostatic blood pressures on people to see what their blood pressure looks like as they go from laying to sitting to standing, because some people pass out every time they stand up. But a lot of that has to do with the sensitivity of these receptors. As we age, the sensitivity of those receptors go down. And then the aortic arch, that's another high pressure artery, is it not? Coming right out of the left ventricle. Again, if the pressure is low, that's going to stimulate those receptors, which is going to stimulate the medulla, which is going to stimulate the heart. So if pressure is low, what division of the autonomic nervous system is stimulated by the medulla? If pressure is falling, Sympathetic, right, sympathetic. Okay, so again, we can see if we have too much stretch, then that will inhibit the heart, decreasing sympathetic impulses to the heart and decreasing heart rate, contractility, cardiac output, and vasodilation. So we have these pressure receptors that are always acting to constantly monitor our blood pressure, and because that's ultimately what's important. We need to keep the tissues alive by good oxygen supply and good nutrient supply, and that can only happen if we have enough pressure to squeeze that plasma, right, to squeeze the components of plasma to the capillary bed and get it out of the capillary bed into the tissues. And the kidneys also play a role in controlling blood pressure. So we have pressure receptors, we have the heart itself, and we have the medulla so far we talked about. But the kidneys also play a role. They release two hormones. One is renin, and another one is aldosterone. I'm sorry, that's by the adrenal cortex. Renin is the hormone from the kidney itself. And when we get into the kidneys, we'll talk about that in a lot more detail. But just know that when we have a decrease in pressure, renin is released by the kidneys, which leads to this cascade of reactions that causes an increase in ADH and an increase in aldosterone. And what does ADH do? Do you remember that from when you took general A&P? Yeah, ADH is the antidiuretic hormone. And a diuretic is what causes a person to urinate a lot. So if it's an antidiuretic, it stops urination. It keeps water in the vessels. So it holds back water. So if your blood pressure is falling, wouldn't it make sense to increase ADH so we hold back water and keep that in the vessels so we have high plasma volume in the vessels? Yeah. And then aldosterone affects sodium retention. So the kidneys will pull sodium and put it back into the plasma, and we know that water follows salt. So if I'm pulling sodium into the plasma, water is going to follow it, and that's going to increase my plasma volume, correct? And that would increase blood pressure. So ADH, aldosterone, and if you look at renin, renin gets that process going with the help of angiotensin II. Like I said, we'll talk more about that when we get into the kidneys, that whole process. Some of this involves the lungs as well, but we'll get into that. But regardless, it's going to increase our blood volume. Renin, ADH, aldosterone, all of those are released within the body to increase blood volume. And that's going to increase pressure. So another one, oops. Sorry, to move this over a little bit. Another factor, so this is just one of those, this is mean arterial pressure. So factors that increase mean arterial pressure. We're looking at pressure on the arterial side of the system. So this is just kind of a nice flow chart. So this is looking at factors, if we work our way from the bottom up, if I have increased peripheral resistance, if my vessels are narrowed because of cholesterol, we talked about that, that can cause increased peripheral resistance. But two other things that can cause that are blood viscosity. And viscosity means resistance to flow. So the thicker your blood is, the more resistance there is to flow. Would that make sense? What would cause an increase in blood viscosity? Which means thicker. My blood is thicker. There's less plasma. Dehydration, definitely. So that would cause a resistance to flow, people that are dehydrated. And then blood vessel length. So the longer the vessel, the more resistance there is to flow. So what does that mean about people that are tall? Are they at more risk for blood pressure issues? They are, yeah. And that's why you don't see a lot of really tall people in the nursing homes, because they tend to not live as long as the little tiny petite grandmas do, because less stress on the body, right? Less resistance to overcome. So dehydration or a high hematocrit, another thing that can cause a high hematocrit are people that have chronically low oxygen levels because of COPD, emphysema. The body responds by making more red blood cells and then end up with a high hematocrit. We talked about the decreased diameter of the blood vessels. What else can I talk about? The one factor that lowers blood pressure is we have atrial natriuretic peptide. I don't know if that's, if we talk about that in here, or is that coming up later? That might be when we talk about blood pressure when you get to the kidneys. I'll have to look that one up. But anyway, for what I want you to focus on in this one is just understanding some of the factors that can affect blood pressure, which would be increased peripheral resistance, and then things, you know, that would decrease blood pressure, fluid loss. If we're losing a lot of blood, that's going to cause a decrease in pressure. A lot of sweating, decrease in pressure. So what do we do for people that have lost a lot of blood and we don't have time? Like, let's say blood pressure is falling right in the room, and we don't have time to do a cross match of blood types and get blood transfusion, but their pressure is falling. What can we do very quickly to bring blood pressure up and keep their tissues alive until we can fix the issue? What? Yeah, IV fluids. Oftentimes just normal saline is hanging right there maybe for that patient anyway. We just open that wide up and just squeeze it in. Some people even squeeze the bag to get that plasma, or to get that fluid into the plasma and bring their pressure up until we can fix the problem. Because sometimes it's internal bleeding, right? We can't fix that. We got to take them to surgery for that. But any, like an abdominal aortic aneurysm, when you have a big vessel like that that has a hole in it, they're leaking blood into the abdominal cavity, we need to increase that pressure fast to keep the tissues alive. All right, now we're going to talk about blood vessel diameter a little bit more. So we have things intrinsically that are part of the blood vessel that can auto-regulate the size or diameter of this vessel. So the green arrows represent things that will do what to the vessel? Look at your key. Open it up, right? Dilate it. And the red is what would constrict. So if I have a decreased pH or decreased oxygen, that would dilate the vessels. If that makes sense? I know it's really hard to see, but if you can write it along the margin or something. I'll put it over here on the board too. I'll write it as we talk. So things that will dilate the blood vessels. Decreased pH. Why do we have a decreased pH? What causes a decreased pH? Yep, increased carbon dioxide levels. So that means this body's working really hard, or something's wrong with the lungs and it's not blowing off carbon dioxide, right? So we have increased carbon dioxide may have caused that. Decreased oxygen will cause dilation. Increased CO2, increased potassium, prostaglandins, that's with injury, the tissues, part of the immune response, prostaglandin release. Adenosine, nitric oxide, nitro, right? We talk about those, that's part of that. Nitric oxide, it kicks in that process of nitric oxide causing vasodilation. That's why we take nitro. And then things that cause it to constrict. So those are the key things I want you to know for dilation, is just decreased pH, increased carbon dioxide, decreased oxygen. Those are the key things. And then for things that would cause us to constrict our vessels, our stretch, increased stretch. So the more blood that enters the system is going to cause those vessels to constrict. Again, we don't want to overfill our vessels and, you know, just stretch them indefinitely, right? Because they would burst. So they constrict as more blood fills those vessels, and that's going to increase the pressure of the blood leaving the capillary bed, right? So can that be hard on the kidneys, those delicate capillary beds of the kidneys, if we have increased stretch because of too much volume? Yeah. So that's why you really have to watch people with kidney failure that their pressures aren't getting too high, because that can be very damaging to their organs to have those high pressure, that high pressure blood flow into those delicate capillaries. And then, so this is happening within the blood itself, like right locally, right, acting on that blood vessel locally. And then extrinsic mechanisms are things outside of the blood vessel. So hormones that are being released, you know, at other areas of the body act on the blood vessel. So atrial natriuretic peptide causes dilation, where ADH, angiotensin II, sympathetic causes constriction, because that helps the falling blood pressure. So ANP, this is where I was wondering where we talked about this one. ANP is the only hormone that raises a falling blood pressure. So increased atrial natriuretic peptide causes an increase in blood pressure by causing constriction. And like I said, there's more, wouldn't you agree, there's more arrows as far as these hormones, there's more arrows for constriction than there is for dilation. Wouldn't you agree, on the right-hand side of this vessel? So it's, our body is well equipped to fix a falling blood pressure, to raise it, right? Because these all act, the sympathetic, the alpha receptors, due to epinephrine, norepinephrine, alpha receptors are going to constrict, angiotensin, ADH, all fix a falling blood pressure. But now, here, notice it says beta receptors cause dilation. Again, where do we find the beta receptors? On the heart and lungs. And that would make sense. Would we want to dilate that with sympathetic response to do the fight or flight? We want good blood flow to the heart and lungs. But it's going to constrict everywhere else. So the muscles, the skeletal, the smooth muscle on the bladder, right? Those vessels to the digestive tract, those would be constricted with sympathetic response, right? We don't want to be digesting when we're running and fighting a bear. We kind of talked about that with the nervous system already. Oops. Let's go back. Whoop. ANP. Yes, this fixes a falling blood pressure. Wait, no, I'm sorry. No, it dilates. It fixes, it corrects a high blood pressure. I'm sorry, yeah. ANP corrects a high blood pressure. Did I say that totally backwards? Oh my gosh. Thank you for catching that. Yikers. I think I said it right at some point, because I said everything else. I said all of those in red fix a falling blood pressure. Oh, okay. Let's fix that then. Yikers. Okay. So ANP, we see an increase in atrial natriuretic peptide when we have an increased blood pressure. So what it does is it dilates the blood vessels to decrease the blood pressure. Make sense? Yes, that makes, okay. I won't even draw it on the board, because it depends if you're talking before or after, right? So we could say increased blood pressure causes increase in atrial natriuretic peptide, and when we're done, because of that negative feedback, we'll have a decreased blood pressure. Okay, thank you for catching that. Okay, so now looking at capillary dynamics. This is one of my favorite topics, because it's just, you see it in your patients all the time. And you'll see it in yourselves as well. So let's talk about the pressures. So I think the best way to do this is to look at my handout that I put out on Blackboard. So if you would take one of these and pass it. Okay, so this is in the learning materials folder, lecture folder for capillary dynamics, part 3. So this is a typical capillary bed, and this is from your textbook. Your textbook does an excellent job explaining this. They have a 2-page kind of blown up diagram of the processes that are occurring here. So this is on page 724 and 725 of your textbook. So you have the arterial side here. So this is where blood is coming in from the arteries, branching down into these small arterioles. So these are the small blood vessels, arterioles, and then that blood enters into the capillary bed. So this is where things that can pass through the pores of the capillary bed can leave and enter the interstitial fluid, and then there's cells out here, right? So let's say this is your brain. Your brain cells are here, and then whatever leaves the capillary bed can enter into the brain cells. So nutrients, oxygen, carbon dioxide, right? Whatever can diffuse across that membrane and into the cells is where this exchange occurs. So this is the capillary bed, and there's some forces of fluid that leave this capillary bed. So every day, in tiny little writing there, 20 liters of fluid leaves the capillary bed. 17 liters re-enters at the other end. So I'm losing 20 liters here, and 17 is being sucked back in down here. By the time I leave the capillary bed down here, 17 liters of fluid has been sucked back in. So how much actually leaves then? Permanently. 3 liters doesn't come back. Where does that go? Right here. It enters into our lymphatic system. So 3 liters empty, it leaves the capillary bed and enters lymphatic, which hooks back up with our cardiovascular system, and then eventually returns back to the blood, right? If you did the lymphatic immune quiz and looked at the PowerPoint, you would see that it goes back to the heart, it goes back to the blood near the heart and through the subclavian vein. So it comes back, and 3 liters remains. So they have this fluid coming out into the interstitial fluid, and then there's cells out here. So there's a pressure. What drives the pressure, did we say, of fluid entering into this capillary bed? What controls that pressure? The heart, yeah, the force of contraction of the heart and the size of the vessels, right, the diameter. So blood pressure is a huge factor affecting the pressure of the blood entering this capillary bed. Would you not agree? So we call that pressure inside the capillary bed, we call that hydrostatic pressure. So we're going to call that, and just to be consistent with your textbook calls it, we're going to call it HPC, HP lowercase c, which is capillary hydrostatic pressure. And that's, like I said, HPC. So what is it caused by? Caused by the force of fluid in the vessels leading to the capillary bed. So if I have a lot of, so think of this like, a good way to think of this is think of this like a sprinkler that you have out in your yard. It's got the holes in it, right? So if I turn on the faucet and I increase the pressure in the holes leading to the sprinkler, where do we see a movement, an increased movement of fluid? Out of the sprinkler, right? You get a really tall sprinkler. Okay, so it moves fluid out of the capillary. And the normal value for this in a typical capillary at the arterial end is about 35 millimeters of mercury. And at the end of the capillary bed, that pressure is 17 millimeters of mercury. So it drops across the capillary bed because there's less pressure as we move through the capillary bed. So 35 to 17, we can say, is the value of that. Whoops, put that right here, 35 to 17. All right, then the other pressure, looking at the capillary bed, we have osmotic pressure in the capillary. So we call that OP, lower subscript c, and that's called osmotic, or capillary osmotic pressure. I'm just going to abbreviate capital P. So capillary osmotic pressure. And what causes that? Osmosis. What causes osmosis? We've talked about that. It's the flow of water. Remember I said water follows solute? So the more solute I have, the more flow of water into that space. So what causes capillary osmotic pressure? It's solute concentration inside the capillary. What are some solutes that can draw things in? In lab, when we looked at blood, the components of plasma, we talked about one protein that really controls blood pressure. It pulls water in. Do you remember what that protein was? Yeah, albumin. That's an example. How about if I had a supersized McDonald's meal? Lots of salt, right? For my digestive tract, that gets absorbed into the blood. So if you have heart failure, do we want you having a lot of salt in your diet, pulling fluid in? No. Okay, because that increases capillary osmotic pressure. So that's going to suck fluid into the capillary. So the direction is into the capillary. And the normal value of that pressure is 26. And what do we know about proteins? Can they leak out of capillaries? Can they dissolve through the membrane? No, no. So they're stuck in the capillary. We don't really see a change. We shouldn't see a lot of leaking of proteins. They're too big. The only way we see protein loss or gain is if we have damage to the capillary bed or less proteins being made because of liver problems. So the value of that is, what did I say, 26? 26 millimeters of mercury. Then we have pressures outside the capillary. We call that the interstitial fluid capillary. So we have hydrostatic pressure. Let's see, I'm going to look at that. What is your interstitial? We'll just call it ISF, hydrostatic pressure, but your textbook abbreviates it HP and then lowercase IF. IF. So that's interstitial fluid, hydrostatic pressure. So the more fluid I have in my tissues, that's going to push on the outside walls of my capillary bed. Would you agree? For those of you in the back row, I see you squinting to see. So wouldn't you agree that if I have more fluid out here, it would push on the walls of the capillary bed? So that is a force that would be acting in what direction? Yeah, into the capillary, out of the interstitial fluid, right? So what is it caused by? What could cause fluid to build up? So it's caused by fluid in the interstitial fluid. What could increase that? What do we call fluid in the interstitial fluid? You already said it earlier. What? Say it louder. Yeah, edema is an example of excess fluid in the interstitial fluid. So the normal value, when we're not dealing with edema, the normal value of that is 0. Because we shouldn't be having a positive pressure in the interstitial fluid because of what? What did we just talk about? What do we have to deal with excess fluid? Our lymphatic capillaries, right? So that's going to always be sucking and draining away any excess fluid. So we shouldn't have a buildup of fluid in a normal tissue. So look at your wrist right now. You shouldn't see it all puffy and swollen, right? Because the lymphatics are taking care of the fluid that was leaking out, that excess 3 liters. Okay, and then lastly, we have osmotic, OP, subscript IF. And that is ISF, osmotic pressure. And that is caused by, same thing as we saw in the capillaries, solutes in the ISF. Should we have a lot of proteins hanging out in the interstitial fluid? Not typically. But we do get a little bit of leakage of protein. Sometimes they can sneak between those simple squamous epithelial cells of the capillary bed. So it's a very small value. So what direction is this going to go? out of the capillary, right? Yeah, yeah. Into the interstitial fluid. And the value of that is 1 millimeters of mercury, just due to leaked proteins. Can't type. Okay, so let's just kind of look at these now. So we have two pressures acting out of the capillary, and that is hydrostatic. And what I want you to think of is hydrostatic pressures push out of the space. So capillary hydrostatic pushes out of the capillary. Interstitial fluid hydrostatic pushes out of the interstitial fluid. And osmotic pressures suck into that space. So capillary osmotic sucks in, causes a movement of fluid into the capillary. Interstitial osmotic is going to cause a sucking in of fluid into the interstitial fluid. So these directions I was talking to are all in reference to the capillary, but if you use the term hydrostatic pushes, osmotic sucks, and then think of where we're talking about the pressure, that'll help you determine which way fluid moves. So osmotic pressure in the interstitial fluid sucks fluid into the interstitial fluid, right? Capillary osmotic sucks fluid into the capillary. Hydrostatic interstitial fluid pushes fluid out of the interstitial fluid and into the capillary. So we have this constant dynamic process based on the pressures. So what would happen if we had high blood pressure? What would that increase? Which fluid is directly impacted by high blood pressure? Which one? Say it louder, whoever said something. High blood pressure. Because I had what? Yeah, definitely. So which one? Right. So HPC is increased in that case, right? Increased HPC. That's a direct, cause on that pressure. Low blood pressure would cause opposite, right? Decreased HPC. Edema. What is that going to cause? Increased HPIF. And dehydration. What is that? Now that depends on the level of dehydration. Where do you think we pull fluid from first? If you had McDonald's for lunch, for example, and you were really salty in your blood, what do you notice? Dry mouth, right? You really need something to drink. So your tissues lose fluid before your blood vessels do. Wouldn't you agree? Do you think the body wants to pull water from the blood to restore mild imbalances? No, we pull it from the tissues. So the areolar tissue of your interstitial fluid is where a lot of the areolar tissue just is that tissue outside of organs that soaks up and releases excess fluid. So in this case, dehydration, we would see a decreased HP. So we're talking mild dehydration, right? IF. So if we had you calculate, so for example, if I gave you some values and had you look at, and that'll be your online activity, is having you look at the fluid pressures in the lymphatic immune system. I had a worksheet in there, but I think I pulled it. It's not in there anymore. I should maybe look at that again. But if I gave you some pressure differences, would you be able to calculate the net pressure in what direction? So if I told you that the hydrostatic pressure in the capillary was 23, And the hydrostatic pressure in the interstitial fluid was, let's see, hydrostatic pressure in the interstitial fluid was, what did I say it is? 0. And then we had osmotic pressure in the capillary is typically what value? 26. Well, let's say we had a really salty meal and it's now 32. And my hydrostatic, what's left? Osmotic pressure in the interstitial fluid. Osmotic pressure in the interstitial fluid is, just keep it at 1. What direction are we going to see? What net direction of fluid flow would we see in reference to the capillary bed? So you have to add up all the pressures that leave the capillary bed. So which ones are leaving? I said you had an HPC of 23. That leaves, right? And the osmotic pressure in the interstitial fluid is going to suck fluid out of, right? So 23 plus 1 is 24 is acting out of the capillary. And then my other two, I said the interstitial fluid hydrostatic was 0, and the capillary osmotic was 32. So I have 32 acting in. So what is my net pressure? 24 is acting out, 32 is acting in. So how much do I have? What's the net pressure across this capillary bed? 8 acting inward. So am I going to, what would I see as a result of that? Edema or increased blood pressure? Yeah. So that's how we can look at some of those factors that affect the capillary bed that we start to see symptoms of edema or increased blood pressure. All right, moving on. Cardiac output. Just define it is all you have to do here. So what did we say about cardiac output? Amount of blood leaving the heart. The definition is per beat or per minute for cardiac output? Per minute. And the normal value is, in a healthy young male, 5.25 liters per minute. 5.25 liters per minute. Two things that affect it, we said was, Emily, I think I heard you say it. Yeah, affected by heart rate and stroke volume. And the formula is cardiac output equals heart rate times stroke volume. And the stroke volume we said was amount of blood leaving each ventricle per beat of the heart. And the normal volume for stroke volume was, you're right, 70 mils. It's in your PowerPoint, so you can just copy it over from your PowerPoint. But this is just a study guide for you to quiz yourself on. And what affects stroke volume? Preload, afterload, and contractility. Yep, preload, afterload, and contractility. And the formula for stroke volume is SV equals N diastolic volume minus N systolic volume, right? How much blood is left in the heart at the end of contraction versus what was there at the start of contraction, which was the EDV. So we did the 120, remember, minus the 50 to get the 70. So it's EDV minus ESV, and that's just from your PowerPoint. So that's slide number 4 on this PowerPoint. And then heart rate. Number of beats per minute, right? That's pretty easy. Normal value for heart rate is 75 is just the average that we'll go with. And it's affected by a couple of different things. Well, it's affected by, kind of those extrinsic things, you know, like age and gender, we can't really control that. But it's affected by hormones and the nervous system, right? Sympathetic and parasympathetic stimulation, and then those other factors we talked about, gender, age, exercise, body temperature. But key things is, you know, we can affect the heart rate, correct, with hormones, and we can affect the heart rate with nervous system stimulation, so that would be the second one. And then the third one are just other factors like age, gender, body temperature we talked about, exercise, obviously. And blood pressure is the force against the arterial walls. What is a normal value for blood pressure? 120/80. What are some things that affect blood pressure? Blood volume was one, so that's why people have to watch their salt and water if they have heart failure. Cardiac output was another one. And peripheral resistance was the other one. So how much, you know, constriction there is or issues with those blood vessels. And venous return is the amount of blood returning to the heart through the veins. And a value for venous return, I don't think I gave you a value for that. I don't know if there is, let's see. We would expect that eventually the amount leaving the heart is equal to the amount entering the heart, so we don't have any net gains or losses, right? So that should be equal to venous return. I'm not going to hold you accountable for that. But what are some things that affects venous return? Yep, muscle contraction. What else? Deep breathing, yep. And blood volume. And then lastly, the different types of blood pressure controls. So we have baroreceptors, those stretch receptors. We have hormonal controls. We talked about renin, aldosterone, ADH, sympathetic stimulation, so nervous system controls can control blood pressure. And then we talked about control right within the blood vessel itself, like degree of stretch. How many is that? Is that 4? Okay. I lost track. So use this as a nice review of some of the concepts we talked about for the test.